Three, two, one. We are live now, sir. We can start.
Okay. Good evening, all our faculties and delegates. I, Dr. Pragna Patel, on the behalf of Intas Pharmaceutical, welcome you again in our new episode of Dental Podcast with the logo of Healthy Smile. As promised earlier, we are coming with a newer and newer topic, and today's topic is Beyond Pyorrhea, cracking the code of periodontitis. So this is an academic initiative of INTA's Altis division, who are the makers of Hyphenac P and Hyphenac SP, which are the brands of aceclofenac, paracetamol, and cerasopeptidase. Little bit about Intas Pharmaceuticals. We are the one of the prominent and strong company with the presence of more than 85 countries. We have achieved significant milestones in R&D. We have developed and commercialized endoxifen, which is the India's first new chemical entity for the bipolar disorder. We are also the first company to launch patented Equilib technology-based delivery system in India, mainly Equilib and Dosi Equilib. We are the first Indian company to launch biosimilars in European nation, that is PEG, filgrastim and filgrastim. Also, Intas is rated as one of the fastest growing company among the top corporates in the based on IPM data. Not only we are higher in Indian setup for the R&D, we also make our footprint in internationally with the motive of supply a high quality and vital medicines. So you can see here we have more than 16 manufacturing and packaging site all over the world. So we are the originator of the first aceclofenac brand in India, named as Hyphenac. And welcome you all again with our new series of dental postcard with the healthy smile. That topic today's is Beyond Pyorrhea, cracking the code of periodontitis. I welcome you again, and I will take this opportunity to welcome our eminent speakers. First, our speaker is Dr. Amit Mishra. He has completed MDAs from the in a periodontology from Dave University Indore in 2011, with distinction of being the first ever gold medalist in MDAs from his university. He has also served as an assistant professor in CM's Dental College, also worked as a head of department at ESIC Medical Hospital, and currently working as a director of Satayu Dental Clinic, Indore's first NABH accredited dental clinic in his area or his city of Indore. He also worked as a mentor and trainer, and he is a founder of Satayu Dental Clinic Dental Study Circle, offering a membership and free training to young dental graduates. He also done a fellow in microdentistry and fellow in Pirif Ward Academy, an esteemed international dental organization. He also uh, given a speaker in many national and international conferences. He is an active key opinion leader. He has worked as a principal investigator for many drugs and a clinical trial. He also has a keen interest in a research, has a numerous national and international publication. He worked as a reviewer and editorial board in number of government index journal, including one of them is World Journal of Clinical Cases and Medical Science Journal. So this is our key today's speaker. Also, I will take this opportunity to introduce our moderator, who is Dr. Rajeshwar Singh. He also done BDS from Sri Aurobindo Medical College of Dentistry in Indore. He done MDS in Conservative Dentistry and Endodontist. He is a gold medalist at his college when he passed MDS exam from College of Dental Sciences and Hospital Rao Indore. He is currently working as a private practitioner at Ek Danta, the complete dental solution Indore, and also visiting consultant at over the 40 clinical dental clinic in Indore. He is a university topper while giving a MDS exam, has a multiple awards for best and second best paper presentation at state and national dental conferences between 2015 to 16. He also invited as a guest speaker and moderator for scientific sessions in 2013. As with our speaker, he also having a various research keen interest in a research and publications, and he authored research on endodontic techniques and adenolysis survey over dentures and temporomandibular disorders and published in various journals. He also having a keen interest in teaching, and he is working as an assistant and associate professor at Index Institute of Dental Science Indore between 2019 to 22. He has a prior teaching experience in College of Dental Sciences and Hospital Rao Indore. He has presented in many scientific papers and posters in more than 30 national and international conferences, major including IACDE, IES, and Asia Pacific Endodontics Confederation event. So, this is our eminent faculty for today's webinar. And now I will take this opportunity to hand over the session to our eminent speaker, Dr. Ankit Mishra. So you can share your slides now.
Yes.
By the time sir is starting, I would also like to add something very small in my introduction, and that is which is not written in my biodata, that sir has also been my teacher since past 17 years, and he still is my teacher. And today I would like to thank Indus Pharma for giving me such a good platform of sharing the virtual stage with sir. So I'm very obliged to sir and all the support staff which is present today.
That is very enlightening, Dr. Singh. Now I will hand over the session to our speaker. Sir, you can go further.
Yes. A very good evening to all of you. Thank you so much, Dr. Pragna Patel, for this wonderful introduction. And thank you, Rajeshwar, for always being with me. And in this virtual event, a very good evening to all the doctors who are present in this. And of course, a warm and a tight hug to all of you from my side. You can be either way. You all are the tiger, and I am the periodontist from Indore, welcoming you all. So today, what we are going to talk a bit about the beyond pyrrhia, the cracking the code of periodontitis. Uh, yes, so thank you for Smile, the Healthy Smile, a dental podcast from Intas. So for periodontics, I always say and I always believe uh, in 2010-11 when I completed my post graduation that periodontics was always been considered as the malnourished child of dentistry from the last 50 years. Uh, well, why I say this as a malnourished child? Because our eyes cannot see what the mind does not know. It's a very old age saying, but it's still very much applicable. You can see the cavities, you plan for the treatment, you can see the gaps, you plan the ortho, you see the impacted tooth, you plan for the treatment. But what you cannot see is something which is related to your gums, which is related to the periodontium. So I'm trying to just open up your eyes for the certain cases which you regularly see in your dental practice. Well, when talk about the periodontitis and periimplantitis, the problem always lie in the soft tissue. Soft tissue, while we are studying, we always used to say, 2 mm ka tissue or itna bada issue. So yes, that is the tissue which is need to be get taken care of. As we all know that inflammation in the soft tissue and the bone tissue disappears. Whenever there's an infection or the inflammation in the soft tissue, the effect will be there onto the bone or onto the hard tissues. So I believe that the articles which are there for the use of biomaterial to treat periimplantitis is incorrect, because we always try to treat the soft tissue, and if the soft tissue, the inner lining is clear, then that will help us to heal or improve the condition of the hard tissue where our teeth are planted, or where our implants are there. So that is what we want to enhance. So we are going to talk a lot about the soft tissue in this podcast. So the first and foremost thing that we require to have a great diagnosis, you need to put a lot of time while checking for the diagnosis. A case something like this, called as the mucosal fenestration. A case where sometimes you do everything correct onto the tooth, but you forget to do on this portion. Or a case something like this, where you may find some enlargement, but you think that probably this might be only because of the inflammation. Well, it may be because of the inflammation, but sometimes it may become the inflammation plus fibrotic, that becomes a combined enlargements.
Mm. Sorry to interrupt, sir. This is Rajeshwar. Uh, I was just asking, like, if we are seeing these photographs of cases, so are they really treatable by periodontics, or we are just watching the cases or something like that right now?
Yes. No, these are the cases which I'm going to show are very much treatable. And even in the further slides, I will show you that what are the treatment outcomes of these cases that I'm going to show you. That is why I'm called as an eye opener. That these are the certain cases, the pre-operative uh, photographs which you see and think that what would be the best treatment plan. Likewise in this particular case, probably many of the dentists are looking at it as the wonderful root stumps and a very good bone extract, place two implants and put the crown over this. But does
Yes.
it really require to remove those teeth?
Okay.
The next slide, the patient sometimes report you with the not happy with the smile. Though you don't find anything difficult in this, so you may plan for a crown, or you can plan for aligner to just close up the gaps. But what about the gingival tissue? What about the gingival height? So these all things we are going to discuss in the further. Okay, sorry. A beautiful smile, but a black pigmented gums. Another smile with again that black, or you can say a chocolatey brown colored pigmented gums. Cases of the gingival recessions, where usually the many of our colleagues thinks to put some composite or some pink composite or some glass ionomer cement or probably a pink ceramic would have been a, but are there some other biological ways to treat them? This is what we are going to discuss in this. Same ways, another case, patient report you with the sensitivity, you put up the GIC and finish up the case. Is it the permanent solution? Another case, you found this case, again a type of a root stem where you just extract and put up the implant over there, or you can remove all, or you can remove these two crowns and then plan for a bridge. So these are the certain cases which you regularly encounter in the clinics. We usually encounter these clinics and we think in the otherwise around. Like another case where you have a insufficient crown height, how does we can treat it so can get a great or a long-term prognosis that we always look for with our treatments. A patient came with a edentullousness, but complaining of that, but complaining or telling something which we are not going to understand. Why? Because he is still stammering or babbling. The reason being because of a tongue tie. So since birth, still having a tongue tie. So these are the certain things which we regularly encounter in our practice. High frenal attachment cases, some enlargement that we see at our regular routine practice, think what could be the best choice, or sending to the government colleges or to the other institutions to work on this. But they are quite a simple cases to be get it done. These type of cases, where we usually think of the immediate extraction and then go for the, the root canal, or the, sorry, extractions, put up the implant or the bridges or something like this. So these are the certain radiographs that I'm showing. These of my around 12 15 years back radiographs, where we did the hemi section or the root resection of these cases, and the teeth are very much in the mouth even in 2025.
So all these are treatable by hardcore periodontics, sir?
Yes, yes. We need to have a good knowledge of the periodontics. Can you see a case here of the absolute bone loss? What do you think of this? Are you going to treat those cases, or are you just going to play a carom with these four teeth and remove those teeth and put up some prostheses like the bridges or implants? So we try to do so. Something like this, a bone graft which is keep on increasing on moving. So what are the regenerative ways of treating those cases? A smile that the patient is not happy with this, a very good looking boy but not happy with the smile. I called it Akshay Kumar smile, isn't it? Yeah.
Totally, totally.
Yes.
So even such a case with so much facial discomfort, deformity, we can plan with periodontics.
Yes, yes. We can plan it out. We have seen amazing results out of it. A
Okay.
case the currently that everybody is looking for the implant cases. So, but unfortunately, if somebody has extracted a tooth and the buccal bone has been collapsed, that case is how we can plan it out into the case so that you can get a great prognosis. We'll discuss onto this also. So after showing all these cases, I can only say that now be attentive. It's now very important to see that what is the objective of a dentist, to create a beautiful smile and a healthy dentition. This is what we all look for. This is all we try to do. So this is what we always look for. But this is a thing what I believe, to create a beautiful smile. But before that, we need to create a healthy dentition that itself will give you a beautiful smile. So, do we need a periodontal view to reach this goal? Of course, of course. So, I always believe to ask a certain question, like after seeing these type of cases, so where do we stand now in the last 15 years? Again, I'm onto the same path, that is it the periodontics is still a malnourished child, that you see those cases, extract and put the implant. 20, 15 years back in 2010-11, everybody was saying the periodontics is all about the scaling, nothing else, and then remove and put a bridge. And now after 15 years, but still I'm getting the answers like this. That why do you want to do all those things? Extract and put the implant over there. But I'm also an implantologist, but I look the case first as that how I can save the thing, the periodontium around. If you are treating a chronic periodontitis case directly onto the implant part, then think that why does that patient got a periodontitis? So certain type of bacteria are already present there in his oral cavity that affect his teeth. So can't they affect the implants also? So think over it, and then only you plan a better way of treating the cases. The certain questions that being asked usually by the some
Some
people.
set of
So
questions which we daily encounter in life. So I'll just read one by one and I'll hope to get
sure.
a proper answer for many of us. So the first one is, are we now capable of saving grade 3 mobile teeth via periodontics?
Yes, via periodontics, we can give the good life to this. And if we treat those cases, basically you are treating the soft tissue. And when you are treating the soft tissue, you are making the bone healthy. So if we able to treat those grade 3 mobile teeth for few years, then that area is very much healthy to receive the further treatment.
Okay. The next is, what is the predictability to cover the denuded root surfaces, which is very found in our Indian population because of hardcore brushing or hard bristles or lakada brushing, whatever we call it.
Right. No, we have got extremely good predictability of root surface coverage. Just we need to find out the correct diagnosis of those cases. Like as during your graduation days, you all have heard or learned about Miller's classification. So you have to find out that which type of the recession is. It is a class 1, 2, 3, or 4. Accordingly, you can guide the prognosis. And as per, if you can see, the connective tissue graft is considered as a gold standard. Of course, with the free gingival graft also, we get amazing results.
Okay. So the next one is, what about the furcation involvement again in posteriors or birooted teeth whenever you have furcation involvement?
Very important question to understand. See, wherever you have a furcation involvement, it is should not be covered with the crown. Many of the practitioners used to put up the finish line onto the root surface, onto the cementum. The finish line is always should be onto the enamel, onto the dentine, not beyond the CEJ, basically onto the cementum areas. The furcation involvement can be treatable if first we need to increase some attached gingiva, or if we're not able to do that, then you have to teach your patients how to do the maintenance over there. Then only the long lasting results will get off to the furcation involvements.
Okay, perfect. So whenever there is excessive gums display, that is more in females and cosmetic zones. Whenever the gingiva is actually at lot of display, or gummy smile, if we in patient's language, which we come across.
See, with the gums display, there are many things are being coming into the market. The current scenario is a lot of patients are looking for the Botox therapy, and the few are looking for the orthodontic surgeries, right? We have to basically evaluate into the holistic way that what best can be done with your patients. If there is some short clinical height, how you can manage, that is a one way of dealing it by periodontically. I'll show you the case of that Akshay Kumar, who was actually an indicated case of an orthodontic surgery.
Yes.
But we deal with the periodontics part and got the excellent results out of it.
Okay. The next one is, what is actually perio aesthetics?
Yes. Whatever, when you talk about the teeth, there has always been a two terminology. One is the white and pink display. The white is considered is taken care by our prosthodontist, and the pink is part that is being taken care by the periodontist. And while talking about the perio aesthetic, there is something called as a golden proportion, a golden proportion that we have to follow. And that golden proportion, how does it go and what is the aesthetic and unesthetic pattern? I'll show you in one slide that what that aesthetic pattern and how should we go with the surgery so that the smile should be absolutely correct or it comes under the golden proportion.
Okay. So, what if we have a case like you also showed us a few slides back, whenever the bone from the buccal aspect is gone or the ridge has collapsed in case of a FMR of implant case, how to augment it, or can we augment it, whatever can be
Yes,
done?
with the augment part, we get excellent results if we use a good biomaterial over there along with the collagen or with the PRF membrane. We regularly augment the cases, and once we get the good amount of the bone, then only we can place up the implants. See, uh, implant is always considered as something like you're putting up a nail into the wall, and if there is no wall, the implant is not going to last for very long. But
Totally.
before going with the implant, we always look for the tooth if we can augment it. So yes, there is also a possibility in both the cases if the tooth is present or if the tooth is lost to augment by the certain biomaterials.
Okay. And then lastly, we have another question, that is, what is smile designing? And I would also like to add a question from my side. What is smile designing, and what are the costings which we can actually take for such cases?
See, again, the smiling designing, I'll consider it along with the perio aesthetics basically. So one thing is for sure, whenever the patient smile, because being the dentist, all of us, the first thing we look always with the teeth part. And if there is any type of enlargement is visible, if any type of recession is visible, then of course those smile is not considered a very beautiful smile. And usually the usual way of doing it with the covering it with the veneers or with the crowns or with the composites. But whenever you address the pink aspect first and then go with, because that is what I mentioned into the previous slide, that I look always with the first with the healthy smile, and that will automatically look onto the beautiful smile. On the costing part, the smile designing, if only the surgical part is considered, because it is a completely an skillful job. So not much of a costing onto the smile designing until unless we add any of the new biomaterial, any of the ceramics or the composites or the other thing. Because these are just, if you say that what is our expenditure is just one scalpel, BB blade, some sutures, some gauze, and some skills in your hand. That's it. So basically, in house, we don't find, and then it's your way of whatever the money you want to ask, you can definitely always.
I think the last point is the most expensive thing. The skill in your hands, the skill in your hands is the most expensive thing the patient can actually afford.
Yes, yes, yes.
Okay, we'll move forward to the next slide.
So the periodontal therapy I suggest is broadly classified into two. One you can say is the perioesthetics, and other you consider it is as the regenerative periodontics. So if you try to define the beauty, it would be futile, as the saying goes that beauty lies in the eyes of the beholder. So now I have a question for you, Raju. Uh, do
Yes,
you
sir.
want to change this smile?
So in my consideration, the smile is very nice.
Yes,
I think
I
the
think
later stages are very nice.
yes, yes. So
So
of course the beauty lies in the eyes of the beholder, right? How
okay,
do you look into it? Okay, there are certain points that we can go for. So we'll
okay,
discuss in the further.
okay,
Although so these are the golden words and certain guidelines are present to define and put for the beauty on an objective scale. So we regularly come across the patients who are content with their smile, not content with their smile and demanding us some youthful, attractive smile and constantly looking for improvements. But the question is that up to how much degree this aesthetic correction is necessary and how much can it be done? So after putting all those diagnoses, now we move on to the treatment plan, that whenever you see a case, how you can see the treatment plan. So always see with the predictability of the procedures, that we all know the prognosis of the case. So there we always need to check the proper case selection and an extremely meticulous treatment plan. So then only you can get the best chance of getting the aesthetic and functional success. The perioesthetics, it required the symmetry of face and dentition, lip shape and smile line, visible red, white relationship, tooth proportions, papilla loss or defect of alveolar ridges. So moving ahead, so we have, as we have mentioned, the tooth related and soft tissue related problems. So we are here to just discuss about the soft tissue related problems. It can be the hyperpigmentation, contours, excessive display of gingiva, recession, deficient alveolar ridge, black triangle, and the enlargements. The cases, the photographs that I showed you in the beginning. So it should always be aimed at improving the aesthetic as well as achieving the maintainable periodontal environment for maintenance. This is the one thing which is being missed by many of the dentists, that they treat at that time, but they don't get the success in achieving the periodontal environment which a patient can be able to manage and able to clean those areas regularly. So the maintenance phase is always been very important while you're talking about the periodontics. As you can see with the hyperpigmentation, the color of the gingiva plays an important role. And of course, this is not in disease, but the cases, the indicated cases are always when you have the wheatish complexion, and when you smile, your gingiva is visible. The gingiva is not visible because this is not a disease which you need to get it treated. Like in this case, the gingiva is visible, so we try to treat. Can be done by the scalpel, lasers. The previous methods were the burrs, cryo units, or the chemical agents, or the electrosurgery. But currently, since I had completed my post graduation, I'm using the scalpel, laser, or the electrosurgery, whatever at that time is available with me. I just try to do the depigmentation by any of the three methods. So this is the first case, as you can see, the chocolatey brown, the patient is smiling. So only we planned with the upper one, not the lower one, because the lower one is not visible. Is it visible? No, it is not. So here you can see the pre-op and the post-operative view. The amazing results that came, and the usual question that being asked onto this is that how much time this pigmentation usually will last. It depends on to the melanin pigmentation of the patient, but I usually see that not before 3, 4 years the pigments usually come, and when they come, they are the very small patches or something like this, not like this, a completely chocolatey brown. You can get it every 3 or 4 years. The another case that we did with a laser, a cute girl came from Singapore and she was not happy with this. So we planned with the laser, and you can see the pre and the post-operative results. We did this just a few days back. So getting amazing result out of it. You can see just a dark pigmented gingiva, and now you can get a pink one. Here you can see the smile. So when we are talking about the gingival contour, the gummy smile, so the reasons could be the mouth breathing, submerged teeth, altered passive eruption, high lip line, drug-induced severe attritions, or any maxillofacial skeletal discrepancies. So the red and white proportion can only be achieved by the various combination of the orthodontic, orthognathic, perio, and restorative. So here I'm only going to talk about the periodontics. Of course, always we need a team approach for any of the cases that we do for. So we have a great team at our clinic. So we all work together with some great technicians to get the best of the results out of it. While talking about the smile line that we're talking about, the smile designing. So here you can see a low smile line. There's a 0 score where you don't find any interdental gingiva visible, and marginal is absolutely not visible. So the management could be the orthodontic extrusion, orthognathic surgery, or the lip repositioning. This is the score 1, which is ideal, where you can see the interdental gingiva by 25 to 75%. The marginal is visible on individual teeth, and this definitely not required any of the treatment. And this is a score 2, the high smile line. The more than 75% of the interdental gingiva is visible. The management should be the crown lengthening. But as I told you before, you don't want to, improve this smile on your scientific proportions. And this is a very high smile line where you need to go for an orthognathic procedure or the periodontal considerations. So this is a pattern that we should look for, aesthetic and unaesthetic fashion. The aesthetic pattern here, we try to go for the central, and the canine should be on the same line. And the 1 millimeter apical, the lateral incisor can be there. So this considered an absolutely aesthetic pattern. This is also can be considered okay where all three are into the same line. Here one side it is onto the apical lateral incisor, other side it is. So these are the some aesthetic pattern that is considered, and these are the absolute anesthetic pattern that we need to get corrected while talking about a smile design. So here you can see this case, the pre-op smile, patient was not happy, and see okay, here you can see the 3 months follow-up, the front view. Here you can compare the pre-op and to the post-operative photograph.
So this entire treatment doesn't involve any orthodontic. This is whole and soul only gum treatment done.
Yes, yes. We only did the gums treatment onto this. Absolutely no orthodontic treatment is there. And I think we achieved something good in this case.
Yes, the difference between the lip line and the gingiva has decreased and his smile has gradually changed a lot.
Yes. So here we did the two things. One is the lip repositioning, and
Okay.
another that we increases the height as per that you have read in your DADS, the height of the central incisor, lateral incisor. So we did the mock surgery before, and then we planned it here. Patient was extremely happy, though he was quite reluctant to go for the orthognathic surgery. So on that part, if he getting this type of result, patient was extremely happy with this. Here you can, I was talking about the aesthetic pattern. The same patient, you can see the right and the left side where there is a straight line between the central and to the canine zenith, and the lateral is 1 millimeter apical to this onto the right and left. So it is absolutely equal on both sides. So that is why we got the result out of it. So now talking on another case, the patient reported with a short clinical crown. So the patient was not happy with this. So we checked for the altered passive eruption. The altered passive eruption, you must be knowing about this, that the gingiva is not completely folded apically. So that is why you can get some pocket depth, but they are not the true pockets. They are the pseudo pockets. So here by the use of a crane Kaplan pocket marker, we have marked certain points. If you can see onto this image. And then we use a 15 number blade by the external bevel gingivectomy. We remove this complete tissue in toto, And here, just immediate after post-operatively, patient was looking absolutely fine. And just the surgery got completed in just 15-20 minutes of a time. Here is a pre-op view, and here you can see the post-operative view. With absolute gingival zenith, pre-op, but the patient again came after a few months and asking to closure of the gap. We put up the many options up to the aligners, up to the like the ceramic veneering, but some economical constraints, he was not up to this. So we just did the composite veneering over this, and the smile was quite great out of it. I will show you the pre-op and the post-operative smile of the patient. Can you see the difference, gross difference in the pre-op and the post-operatively? And if you can check it with to the smile designing, there also you can see the how much amount of the gingiva is visible here and what how much is was into the pre-operatively. Now, while talking about some recession cases, need not to mention much about class 1, Miller's class 1, class 2 cases, but just to show you the diagram of it. So class 1 and class 2 are having a great prognosis. Approximately best into the class 1, slightly less in class 2. In class 3 and class 4, because there is a loss of the bone tissue, so at their point, we don't get the good prognosis. So the treatment plan for these cases, 1 and 2 are treatable, 3 and 4 are not treatable. So here another case of the recession where we did the pouch and tunnel technique. We just make it a pouch over there without reflecting the internal gingiva and the tunnel, and then procure the connective tissue graft from the palate. Just a time of just a 10 minutes or something we took for removing the CTG from the palate, placed it there, and here you can see the pre-op and the post-operative result, a complete recession coverage over there. Another case of the same entity of the recession. Here again we did a connective tissue graft, and after 2 months of a time, even the papillaries are also also visible while you seeing onto the gingiva onto the post-operative cases. The another case of coronally displaced flap, a very simple procedure. You just mark the 2 incisions horizontally and 2 onto the vertically and pull it apically. Partial thickness flap, reflected the partial thickness, suture it back, and an amazing result. So how much expenditure, how much should I charge from this, Dr. Reshwar?
I really don't know, sir. Like it is looking so easy, but I definitely know that this must have been very difficult. It just
No, I mean to say the armamentarium you're using in these cases are almost negligible. Just a scalpel and a suture is finish it of the case.
I
And the
think
biological way, the ethical way of treating your cases. This is one of my favorite. Here you even don't need the suture to cover those recession. This is called as a semi-lunar coronally reposition flap by Tarnow. If you found some class 1 recession over there, but they are only applicable in the maxillary, not in the mandible. So here, if you found these type of recessions, there you just give partial thickness flap and leave it. And by the sake of gravity, it will fall it down. And you can see the pre-op, and now you see the post-op just after the 15 days of a time. A complete recession coverage in these cases also. Now, this is a one of a case that probably the many of the doctors who are listening this are waiting to how do you correct those mucosal fenestration, and is
yeah,
it really difficult to treat? Not much.
because we can see discoloration of 1-1. So this is a classical case of trauma in young
Wrong.
age or early teenage, and it is usually associated with a swelling, vestibular swelling, or such kind of what we call as fenestration. And
Absolutely.
go for a
So
CT for such cases, so we see that there is no bone, buccal, palatal. So we are confused that whether to extract or go endodontically. So it will be very nice now in the coming slides. We really want to know what we can be done for
So
this.
basically, these type of cases are usually being encountered into the regular practice where the patient has got some trauma during his childhood and now having some pain or the swelling into the vestibular areas. Basically, the patient report you will get such type of X-rays with some internal resorption or probably the not fusing the roots at the apex. So there we complete our endo work. Probably at some point of time, Dr. Rajeshwar will tell much about those endo part. I'm not going much of the detail about these endo part basically. He's master in this now. So after completing the root canal treatment of those things and putting all the biomaterials inside, and when you're ready to just put up the crown, you see those mucosal fenestration. So what at that time what we do is again just giving some vertical incisions and the horizontal incision, reflecting the flap. And when we reflect the flap, we found this. As Aisha was saying that there is absolutely no bone into the buccal area. So absolutely no bone over there. So we did some apicectomy over there, clean all the periapical debris from there, put up some graft over there, got the connective tissue from the palate by trapdoor incision, put the graft over there to correct the loss of bone onto the buccal side, and then put a connective tissue graft over it so that the fenestration will be closed. Here you can see that after putting the graft and the connective tissue over there, you just suture it back. And the result that you can see, you probably may like the result that the complete mucosal fenestration has been closed, and you get a great prognosis of this case. And afterwards, we planned for just a crown over there. Just put a crown over there, and this is the pre-op and the post-operatively smile of the patient. The tooth was very much safe. Well, you're talking about another case into the lower arch. I was continuously talking about a maxillary, now something into the lower also. So there again, you got the same type of a problem. If the patient got a trauma over there, the root canal has been done. And while planning further, you found again a fenestration. Reflecting a flap, you can see into the last slide, no bone onto the buccal area. So what we have to plan, again, the same thing, put up some graft, put some connective tissue over it and suture it back. Quite easy to, quite easy that these things can be very easily treatable, but not every time you will get the same result. So here, after doing all these things, patient reported again the fenestration was closed, but there was again a recession that we found. Fortunately, it was a class 1 recession. So you can see the fenestration has been closed, but you can also notice that there is some amount of the recession that you can find out on this slide. So if you are feeling sleepy, please wake up and just you can see that what more you can do on these type of conditions. So you can see a class 1 recession over there. So what we did, we just give an incision, did a lateral pedicle over there and cover up those area. And you can see the comparison of the pre and post treatment. Again, we have completed the recession part is over. The slide bit that you can see, it is in the healing phase. So by the creeping attachment, we have got a complete recession coverage in this case. Now, this is a one case close to my heart. Patient was being advised by many dentists to go for extraction and place up the implant. I planned something else in this. I did a apically positioned flap in this case and would love to share the result of it. We just reflected a flap, did some osteotomy, got some good amount of the tooth now is visible over there. We apically positioned the flap, suture it there. And here you can see the post-operatively, this much amount of the tooth structure that we got after completing the surgery after the healing phase. Here you can see the pre and post-operatively view. Here you can see the very simple that now you can put up the post and core and the crown over those teeth. The pre-op and post-op is showing a significant. The only thing you need to understand that you need not to go for a such gingivectomy that you go beyond with the adjacent teeth. So that also you need to be managed. Can you see it over here? I'm not going beneath the canine that I have just did a completely up to this level. You have to maintain the mucogingival junction and the attached gingiva also for the maintenance phase. So this is the condition that we got. So planned crown over this, but after 1 year, as there was a one recession into the one case, so we found some recession because there was a deficient attached gingiva over this. All other 3 teeth attached gingiva was there, but here it is deficient. So this case was being referred to me again. Sir, correct this. So I did a free gingival graft only with that particular tooth, uh, partially remove the epithelium, get the free gingiva from the palate, and suture it there. And the post-operatively, you can see that even we can get the attached gingiva over here. So now the patient is able to maintain this area, and you can get the long-term prognosis of these cases. All right. So from here to here, I think saving the tooth, this is what being taught during our college days. Of course, in clinic, we want to extract and put some new things, but I always believe in those saving these teeth. Wherever it is required, I also do. But here, these are some perio cases. That is why it is cracking the code of periodontics, right? Another case of free gingival are routine cases that we used to do. Here, I just put up the graft, put the co-pack over there, and the result is quite satisfactory after say around 15 days or 3 weeks of a time. Here is one case that being referred to my practice by a patient. That patient was not happy with the black triangle and with the recession. So they suggested to go for a crown with both these teeth, but patient was not sure about to go with the crown over there. So they referred to me. I just did my gold standard, remove the connective tissue from the palate, place it there post-operatively, and here you can see the pre and post-operative result. The complete recession coverage along with the black triangle has been completely closed into the central incisor. The patient and the doctor both were very happy after seeing these results. Some enlargement cases that we encounter at our practice, do some internal bevel gingivectomies, removing of it, and then send it for the biopsy. Got the peripheral cementoosseous fibroma, suture it back, and you can very easily see the pre and post-operative result. A case came from a village. They were thinking about some cancer or something. There was nothing. Some enlargement of peripheral cementoosseous fibroma. We have given them the report. Patient was very happy with this. Some other cases like some enlargement because of, I think, this case of the calcium channel blocker. I think it is a nifedipine or the amlodipine enlargement. I don't remember right now. So we again do some internal bevel gingivectomy, uh, marking the pocket, giving some incisions over there, removing the tissue in toto, suture it back, and some pre and post operatively still into the healing phase. The last photograph that I had of the healing phase, that is why you are seeing some gaps over there. So, of course, some patient didn't turn up after getting this result. Some ridge augmentation cases that we're talking about, it may be the Siebert's class 1, class 2, or class 3, where we go with the treatment part like this type of somebody has extracted some lateral or canine, I think, and this much of the defect that you get. I don't know how to get it treated. So I just gave the incision, got some graft from the ramus, and after reflection, this I reflected the flap, autogenous bone graft procured from the ramus, placed it over there, suture it back. Here you can see a lot of difference over the apicocoronal width of the area. There you can place some implants and then you can mask it with some ceramic, pink ceramic over there. So yes, it is joining the hands to make a smile beautiful. Another case of a ridge augmentation. A very less bone was there, so we reflected it, put up a bone graft, put a membrane over there. This is after 6 months, we got this result. Open up the flap, place the implant. Here you can see, and the radiograph that you can see is the pre and post operatively. The shade match and everything was great. Patient was happy. Such type of cases you must encounter in your clinic where you have a very less vestibular depth. So whenever you go for any of the RPDs, the patient keep on complaining, sir, idhar chubh raha hai, you're getting ulcer here, you're getting some problem here, keep on trimming. And when you keep on trimming, there is now a space. Now patient is again coming to you back saying, sir, whatever I eat, it goes inside our denture. How would I eat? So the problem is keep on being there about the RPD cases or with the partial denture, removal partial denture patients. So a very simple procedure of an Edlin Marshall technique, a very old technique where we just give an incision and put up the epithelial sutures directly into the bone and the connective tissue over it. And here you can see the post-operative result after 10 days of the suture removal. Here you can see the pre-op, only the vestibular depth of 5 or 6 mm, and the post-operatively, now you're getting a vestibular depth of more than approximately, I think, 12, 13 mm. So these are the some simple cases that you can do in your private practice. In the denture cases, again into the mandible area where you don't find a sufficient bone, here you can also plan with some Adler Melcher technique, a vestibuloplasty technique, where you can get the deepen area where you can place up your because you have always been a less bone while you put removable dentures over there. So these all are the parts of the periodontics. That is what I would like to share with you all. Another case of having a less vestibular depth, the same way we did. This is a case of a crown lengthening by osseous reduction. So here is a pre-operatively, and just the post-operative, you can see the white area. So if you directly put a crown over this, the chances of the dislodging of the crown or the fracture of the tooth will always be there. But if you are here, you are going to get the ferrule effect. The ferrule effect that you will get out of it, the prognosis would be great while doing it. But again, remember while doing these cases that the gingiva should not, the aesthetic pattern should always be there. Here you can see the post-operatively, the gingiva is at the same level. So while doing a crown lengthening, also you should not go beyond the attached gingiva or beyond the mucogingival junction. Ki sir, dekho itna bada tooth, but where to place basically? Then you need to go for a recession coverage over there. Another case of crown lengthening, I was talking about a case where the full mouth zirconia was placed and a single tooth has been broken. So there again we did a crown lengthening. The later on we placed a post and core and put a crown over there. Regenerative procedures where you can get such type of bony defects over there. So the best is the current way of doing is with the use of a PRF. We have the centrifuge machine in our clinic. Just get the 10 ml of a blood, get a centrifuge at 700 to 900 RPM for 10 minutes. This is the what you will get the PRF, and you can mix it with the bone and place it inside. The pre-op and the post-operative is quite a good that you can get feel the amount of the bone loss here, and here it has been completely being covered. Case that was talking about in the initial about can you save the grade 3? This patient I treated in 2008 and did the extraction, did the root canal, did the reimplantation, put up the splinting over there, and finally these all teeth are removed in 2023, and then we planned for an implant. So I think we have done a decent job in this patient, that the tooth was being there for 15 years in a very functional way. So there are the certain cases which we have to look for. You can see the bone growth was keep on occurring and patient was keep on coming within like every 6 months or a year just for a regular checkups. Another case of reimplantation. The tooth was mobile. We did a root canal, put up a splint over there, and you can very much see that there is some amount of the bone growth is getting out of it. After doing all these perio cases, the one thing which you always require is the maintenance phase. Always plan to have a toothpaste uh, with a double zinc, with the arginine toothpaste and some mouthwashes. Try to get the mouthwash of the least concentration of 0.12%, because these are the only the low staining formulations basically. All other are having which are present in India are the 0.20. On a long term use in the perio cases, the patient will end up getting some staining on their teeth. So the 0.12%, this is what I always recommend to my patients. Not to mention much about the mechanism of chlorhexidine. And I prefer to go with the battery operated sonic toothbrushes, because to check that they don't put a lot of pressure over there. And these type of toothbrushes, if you go for a better company, they always go with the that if you put a lot of pressure, it will automatically stop. So that will help us my perio health or my patient's perio health to be improved. At some places, I used to go with the water flossers in between the tooth. If not, then patient can use the incidental brushes. And for all those things, I always prefer this thing which probably you all have learned during your pedo, the tell, show, do technique. I used to tell, sit, let my patients sit, give them a 15 minutes, 30 minutes, so that I can show them how to use these incidental aids in between the teeth. And this is a one very good thing you can incorporate in your regular practice. That give some time and show them how you can do them, how they can do this in their home care regime. So thank you so much, Intas. I can say that I proudly say that I recommend a lot many Intas products in my practice. And one of the thing that I used to recommend a lot to my patients is their Calenta Frec, which is come with some Cissus quadrangularis, and this helps a lot of bone growth in my implant cases, in my perio cases. And thank you so much, Intas. So just to conclude, that a successful integration of aesthetics and functions do not emerge by chance, but rather by a meticulous development of the clearly defined parameters and incorporation into the design of the prosthesis. So the appropriate case selection and a very careful treatment planning is required to get absolute satisfaction of your patients.
Thank you so much, sir. I would like to take a moment here and really thank you. And it is very outstanding that even after being in practice for almost 20 years, you have documented all your cases till date. You have so much of good follow-up. So that shows the faith of the patient in you that they are coming for follow-ups for more than 15 years. Like uh, I think most of our viewers, including me, we don't even have practice of more than 5 years or 7 years, and you have patients who have recall value of 18 to 20 years. So that is very significant to learn from you. And hats off to the documentation of every step, like every step, every X-ray, every pre-op, comparison of post-op, and the follow-up. People usually do the pre-op, the post-op, the follow-up is missing in maximum number of patients. So once again, and I'm really happy to be your student, and I think you will have many students from the viewership today. And I think now we can hand over the thing to the team Intas. And I think Mr. Sushil sir, the vice president from Intas, is there, who would like to conclude with the vote of thanks. And I also like to thank Dr. Pragna that she can take over from us now.
Sir, we have some question and answers, so we can
Yeah,
take that first,
sorry, we
and
have
then
some questions also. I'll just read out a few questions from those. So, sir, the
Sir,
question is,
you can stop sharing the screen so that we will pin you up. So both of you only seen in the for the.
Okay.
so, sir, one of the question is, what's the role of salivary diagnostics in early detection of periodontal diseases?
Into the clinical practice, I don't find a much use basically of the salivary diagnostics into the early periodontics cases. Uh, Basically, see, if you see, there are certain patients which are caries prone individuals and which are the periodontal cases. The caries prone individuals, they are having a very high glucose content. When they have a very high glucose content, they are very prone of getting the continuously caries over there. And whenever you see with a lot of calculus over there, so that itself suggests that patient is having a high chances of the calcium, different type of calcium present into the saliva, and that is why here keep on continuing deposition of the calculus over there. So basically, these salivary markers, if you go on to the academic zone, there are there you can understand with the very initial part that okay, this patient is going for this, but onto the clinical aspect, by seeing onto the lingual aspect of the any of the patient, the amount the calculus, because there you get that Watson's duct, the extension duct that get open into the maxillary area into the lower side. So there, the amount of calculus, if you see, there many patients came into my practice where I see a lot of caries over there and not a single calculus over there. So these type of cases, they don't consider them as a periodontal candidate, but very important to go with those things to prevent the caries on those particular individuals.
We have another set of interesting question, that is there any artificial intelligence, AI, or machine learning being used to predict periodontal disease progression? Is there any such research going on where AI can tell you the progression of periodontal diseases?
The progression of the periodontal disease, basically, you don't need to get an AI. It's a very simple AI that we can say is your Williams graduated probe in your clinic. If you just walk around the Williams graduated probe around all those teeth, And if you found that some bleeding within the 30 seconds of a time, that means that candidate itself is a case of the chances of the periodontal disease would be high. There's no need to go for an extremely sci-fi onto this or a rocket science to check that whether periodontal disease can increase by this or not. You can ask simple to the patient, when you bath, do you get any bleeding over there? No. But so when you bath with your teeth, like a brushing on your, if you're getting the bleeding, so that itself suggests that you are a good candidate of a periodontic, of a periodontitis. So better to get it treated at early rather than delay.
Okay. So the next question is from the audience. How do systemic conditions like diabetes or any cardiovascular disease alter the periodontal treatment plannings?
A lot, a lot. A great question. Thank you. Thank you so much for asking, whosoever has asked this. In my 17, 18 years of perio practice, I have diagnosed more than 100 patients who are not knowing that they are diabetic.
Okay.
They just came to my clinic for their regular dental treatment, and just by seeing the condition of the gingiva, the multiple abscesses over there, the type of gingiva, the fragile gingiva over there, I just called a glucometer that has always been available at my reception, check their sugar level, 440, 500, 370. I just tell them, you don't need now to me, first go to the endocrinologist or any of the diabetic specialist and get your sugar checkup done. And while talking about this, I can proudly say that during my consulting at many clinics, at one of the clinic, which is a diabetic hospital basically, there I did, along with an endocrinologist, a lot of patients where they are having onto the insulin up to the 80, 90 units of insulin per day. And just after doing the prophylaxis, then the perio surgeries, within the span of 15 days or some, the insulin that they required has reduced significantly by 30 units, 20 units. And they become like, how does this, doc? I said, मुंह है ना, I mean, आप आपके घर में प्रवेश करते हैं तो उस समय अगर गंदा है तो घर में भी कीचड़ आएगा ना. So on the very simple note, you can say if you have a lot of bacteria, biofilm present over there, so at that time, if you eat anything, that is going inside, and then there is a lot of changes there. There you can get. Even I suggest to my patients sometimes that even after you getting a viral infection, please change your toothbrush. You know,
Okay.
so there if you see, and along with this, I would like to add there is a one article from Japan. I read that article that they found the more amount of the notorious bacteria in the patient who is having a periodontitis compared to a public toilet seat. So, so you can imagine that how much infection a patient is carrying inside his mouth while he's eating or while he's brushing. So it all affects a lot of oral health, premature, low-term baby, the cardiovascular and sugar I have already mentioned.
Okay. So we are actually running short of time, but I'll still take another question. How do you motivate patients who are asymptomatic but at very high risk in periodontics? How do you
Asympt- yes,
how do
yes.
you motivate patients who are asymptomatic but are still at high risk scientifically but are totally asymptomatic? How do you motivate them in your practice?
In clinic, there is a very simple way of doing it that every clinic should have an intraoral camera. You need not to speak a single word to your patient. You just start capturing all the images, starting from the lingual aspect of the lower to everywhere. And then you need not to basically motivate anything. Then you just start walking off the probe everywhere. Again, you take up the camera, you show it them, and then you can have a very good discussion with the patient. This is the most easiest possible way. Otherwise, there are so many myths. Cleaning करने से दांत हिल जाएंगे and all those things that you must be hearing day in and day out, even in the today's world.
Okay, so I'll also like to continue to ask another few set of questions because there are really interesting questions and many audiences have sent a lot of questions for you. So, uh, is your flap surgery the only option for an aggressive periodontitis?
Right. First, you need to understand that flap surgery is not a flop surgery. Yeah. So the aggressive periodontitis has always been there is an incisal and molar relationship. Incisor and molar relationship. Now you have to check that whether that aggressive periodontitis is into the initial phase where you need to just treat an incisor into the molar, or now the aggressive periodontitis has been moved on along with the chronic periodontitis because patient is not maintaining it up. So yes, for any of these cases, see, there is directly you cannot jump it onto the flap surgery. You have to start with the oral prophylaxis, then you go for your root planing part, then you can go with your local drug delivery, a maintenance phase, recalling your patient, keep on checking the pocket depth, and when the pocket depth continuously get reduced, there you can do with the LANAP procedure, with the laser new assisted procedure. And still, if you found only one or single pocket is there, the LANAP is great. But still, if you there see that there is some bony defect over there, so how will you cover those bony effect? At that time, you have to just reflect up the flap, clean those areas, put up the some biomaterial over there, suture it back. See, I just suggest you something like I suggest to my patients, if you have a pocket like this, if you have some deposition up to this level, I can go the subgingivally. But if it is beyond 5 millimeter, how would my scaler would reach up to this level? On that part, I have to just reflect the pocket, clean those areas and suture it back.
Then we have a question. What's the future of regenerative periodontics? Can we bioengineer lost bone and tissue? I'll just repeat it. What's the future of regenerative periodontics? And can we bioengineer lost bone and tissue?
See, in the initial only into the second or third slide, I have mentioned that the articles over the treatment of the peri-implantitis are wrong in my way. The problem is always lies not into the bone. The problem is always lies into the soft tissue. So if you start treating the soft tissue well, the inner lining of the soft tissue. See, this is your gingiva. Here is your bone. Here is the inner lining where you find all your actinobacillus, actinomycetin, comitans, profanum gingivalis, treponema, denticola, everything. Then those all are killing your bone basically. So whatever is the biomaterial, if you place it here, but if you are not treated this well, you're not going to get the desired results out of it.
Okay. So then there is another good set of question that how do you use behavior changes and visual things or habit changings to improve the oral hygiene compliance? Like I think you just answered it with the tell show do technique.
See, this is a very commonest practice in my clinic that if I want to tell my patients to do a brushing, I usually get the new brush from my pharmacy, show them. If I teach them the flossing, I teach them by holding their hands up to this. Like I like a flosser, not that the straight one with a U. I just like that gulel wala, this one. So because those type of flossers only can reach up to the 7 or 8 areas into the lower, into the upper and everywhere, right? Then you have a multiple sets of the interdental brushes from the narrow. So you cannot just write it down and send it to the patient किसको कर लेना कैसे करेगा वो. So I never like teach any of my patients to use that floss of the loop and then do it. I just give them those type of flossers which the patient can easily do, and even when they are outside, कि कहीं किसी ने बजरंग बली का प्रसाद खिलाया नारियल अटक गया, so there only they can just clean it up rather than putting the prasad raat tak and then causing the cavities over there. So the trial should do technique is the best technique to teach your patients. Even the water flosser does an amazing job, but if you need to teach them.
Okay, so I'll just wrap up with my one last question, which is very adhyatmic question, that can mindfulness or stress reduction play a role in your periodontal outcomes?
Stress reduction can play a role everywhere in your body. See, everywhere in your body. If you are the de-stress yourself, if you are doing those oil pullings and the other Ayurvedic methods, basically your eating habits, your breathing habits, those increases, and this all help always to rejuvenate your gums area. As like I always tell my patient that after even you're doing your brushing, you need not any of the gel to massage. You can just wet up your finger and just doing the massage basically. You need to increase the blood supply over there. The same way when you're doing any type of pranayam, yoga, in any part of the body, if you're increasing the saturation of the oxygen, it is always going to help the gums to improve. But on the other hand, if you're eating something, it need to be get cleaned. You need to have brushed, then only you get the healthy environment. But of course, the de-stress yourself, this is the one thing we also doctors used to practice a lot. That is why we are still able to sit at 9:20, 9:15. We started our morning since 8.
Yeah. Okay, so thank you so much, Amit sir, and it was very pleasure to hear you as an audience, as a moderator, as a student, as I've always been with you. And before wrapping up from your side and my side, I would like to again share the podium for Mr. Sushil Kumar Voraji, who is a Senior Vice President, Sales and Marketing from Altis and Aleria Division. We would like to end the vote of thanks on official note. From my side and sir side, we would really like to thank everyone who heard us, and it's a good night, everyone.
Thank you so much. Thank you.
So good evening, everyone, and on behalf of Intas, it is my privilege to extend heartfelt vote of thanks to all who contributed to the success of today's enlightening medical session on Beyond Pyorrhea, cracking the code of periodontitis. First and foremost, I would like to express our sincere gratitude to our esteemed speaker, Dr. Amit Kumar Mishra, and our moderator, Dr. Rajeshwar Singh. Dr. Amit Mishra, thank you so much for sharing your deep knowledge, clinical insights, and your surgical experiences in such a clear and a very, very engaging manner. Your expertise has truly enriched our dentist understanding of the complexities involved in managing and salvaging periodontitis. We are grateful to our respected dental surgeons and residents who took out time to attend this session amidst their busy schedules. Your presence and active participation definitely reflects your unwavering commitment to advancing patient care. I would also like to acknowledge the contributions of my fellow field and marketing colleagues in Altis and TAS and the support teams from our medical department who worked definitely behind the scenes to ensure that this event was well coordinated and seamlessly executed. Let us carry forward the learnings from today into our practices with renewed dedication towards improving outcomes in dentistry. Thank you once again, Dr. Mishra, Dr. Rajeshwar Singh, for such a collaborative learning session. And thank you so much, and hope to see you more in the future. Just for your information, sir, we had 14,500 registrations for this program, and we have a live audience of close to around 1,400 dentists on this session today. So I'm sure that this definitely talks miles about the fact and the interest of people always hungry for learning more and more. So I'm sure that this would have enriched everyone who's there on this platform today. And we also have archives of this, which is loaded onto our system. So for all the dental surgeons who are not able to attend for some reason or the other today, would also be able to revisit this, through the archives and on a recording of the shoot. Thank you so much, sir, once again. Thanks a lot,
Have a
everyone.
good
Good
night.
night. Thank you.
Yeah, we can close.